Good evening, everyone. Welcome to this evening's meeting of the HSCRG. If I just go through the administrative stuff first. The meeting will be live streamed to the public, and a recording of the public part of the meeting will be available on the website 24 hours after the meeting. Remote participants joining the meeting can ask that they use the hands up button to indicate they have a question or comment. And would members and officers please remember to switch their microphone on when speaking and off when they have finished speaking, and speak directly into the microphone. And would everyone switch off their mobile phones or place in silent mode? Okay, apologies, Frab?
None, Chair.
Thank you. Minutes of the meeting on the 13th of April. Okay. Minutes of the meeting on the 17th of May. Okay. Minutes of the meeting on the 17th of May. Thank you. Any disclosures of interest?
None that I'm aware of, Chair.
Thank you. Any urgent business?
None, Chair.
Thank you. Any references from committees or other bodies?
Again, none, Chair.
Chair's update. I have nothing to report from last meeting. We have received the update on the COVID-19 report, so that should be, you should have a hard copy of that in front of you. Okay, so yes, we go straight into the COVID-19 update. Sally?
Thank you, Chair. So the paper was circulated yesterday with the current position. As in the last meeting, we don't have the same level of data that we did have previously. So the report is less full than the reports that we have had throughout the pandemic. So we don't have the case rates overall for Luton anymore. We have modelled case rates for England and Blmk because there is no longer the widespread community testing that there was once. But you can see that over the last couple of weeks, there has been a bit of an increase in the numbers of cases modelled both nationally and across Blmk. And there has also been in the last week a small increase in the numbers of cases within the hospital. And last week we had 2 deaths from COVID. But the numbers in ICU are remaining very, very low due to COVID. So relatively stable, but looking like there is a small increase in cases. There aren't any new variants of concern, and actually the numbers that are now sequenced of cases that are genetically sequenced is very small. I know nationally in the news there is concerns about the Omicron subvariants BA4 and BA5, and we've only had a couple of those in the sample that gets sequenced in Luton. So I think we can sort of make some assumptions that the numbers of cases increasing is due to those subvariants because they seem to be more transmissible, but we don't know that, so I can't really report on that properly. All of the infrastructure and governance that we had around outbreak management and management of response to COVID has largely stepped down now. So we are monitoring the data in the background, and we did still have our COVID health protection meetings monthly, but we've just stood those down until further notice. We don't have any cases, any outbreaks in care homes anymore, so we've also stood down our care home outbreak management meetings. The main thing that we are still focusing on, though, is the vaccination programme. We do still have low uptake of the vaccine compared to national, although it's still well underway and increasing. So we still are seeing a good number of vaccinations on a weekly basis, including first doses. So there are still people coming forward and kind of making the decision now that they're happy to be vaccinated, which is really positive. So we've got the Wellbeing Hub in the Mall that is continuing to be a really good, strong offer. continuing to deliver a good number of vaccines per week, working with the CCG, and we're looking at what the potential for that location is for other vaccines and public health and health offers. So there is a lot of potential there, and we'll continue to look at that and develop it. We have a mobile vaccination vehicle that we have had. So obviously earlier in the pandemic we had the bus, and then we had another mobile vehicle, and we've now got another one that we can be using to go to communities, go to events, and do outreach. And it's got a wrap on it that's not just specifically around, so the artwork on it is not just specifically around vaccination, so we have some flexibility of what we use it for over the next 6 months where we've hired it. We are continuing to roll out the Community COVID Vaccination Champion Programme, which we were successful in getting additional grant funding for in the new year. And a large part of that is working with community groups, undertaking activities such as organising events, training peer champions, radio interviews, distributing material. So the idea is that it's much closer to the community in terms of getting the messages out there. So I'll stop there and open up to any questions.
Thank you. Any questions? See?
Yeah, so obviously you've got here with the care homes that there's currently no outbreaks. You mentioned obviously as we know that there's not a large widespread testing. I'm aware from my family's personal experience that anyone that's going to see someone in a care home still has to have negative tests. Is there still regular testing within the care home setting?
There is for both staff and residents. It's slightly reduced in terms of the frequency now, but there is still regular testing, and that hasn't changed. And for a while we were still seeing positive cases coming up through that, though largely asymptomatic. But at the moment there aren't any outbreaks at the moment.
Thanks. Also, with the spring booster program, because obviously it's not in the news as much as it used to be, I'm guessing these people are eligible for second boosters now. What's the eligibility criteria of people coming for booster vaccines at this time, or second boosters, as it might be in some cases?
It's similar to flu, so it's the older age cohort, and then people that are immunosuppressed or have certain long-term conditions. So it's a very similar cohort to the annual flu vaccine.
David?
Thank you, Chair. Thank you, Sally. That's a good report. In terms of what I can see, variants of concern, you indicated that there's no variant of concern. My understanding is after the Platinum Jubilee celebration, there was a concern about the Omicron lineage B4, B5. I'm not sure whether you've been made aware, which is very infectious, but the good thing is it's not as deadly as the Delta that we had. So for me, the question is, we should continue to monitor and do the sampling or whatever we do to make sure that we do the PCRs, not lose that, because if there should be changes again and there's a deadly one, are we ready to be able to fight the infections or stop people from dying? That's my number one question.
Yeah, so the numbers of PCRs that are sequenced to see which variant they are is nationally decided, and we don't really have any control over that. I did check actually just this afternoon before coming to the meeting. We've had 2 BA4s of the subset that are PCRs that are sequenced. So that's not necessarily that we've only had 2, but we are keeping an eye on it locally. So we do get that information, and we can keep an eye on it locally. But the decision around which tests are sequenced, it's not a local decision, it's a national decision. But we have got the data of what the sequence is showing through our line reports, so we can have a look at that. And we've just had 2 BA4s.
see that you've got the uptake levels, it's still very low. And I know you're doing everything possible. So have we done any intelligence to understand why people are not taking the boosters?
Yes, we've done a lot. So we did very early on, we did some sort of market research, focus groups, interviews with people to try and understand reasons for being hesitant around the vaccine. And there was quite a lot that came out from that. There's some people that are really absolutely anti and would be very difficult to change their mind due to various reasons around mistrust of the government and various other issues. There's some people that were sort of biding their time and were saying that they might be persuaded if enough time passes. And I think that's why we're seeing some people coming through now for just first dose still. And some of it's around word of mouth and trusted views of friends and family. So there was quite a lot that came out with quite a detailed qualitative research around that. And then we have also been doing more recently phone calls using GP lists. Initially we were just doing those that hadn't been vaccinated at all, and now we're doing those that haven't had their booster. And there's a whole range of learnings from that. A lot of that is wrong phone number and address, or not being able to get hold of people, which is frustrating. And then there's some around not knowing where to go still. And so we're just trying to have those helpful conversations with people to inform people. Obviously, not knowing where to go is not for the booster. That would be first dose, and not knowing the process initially. But I think some of it still then carries through to the booster. What we're hearing a lot as well is that a motivator is around travel. So if people know that they need to be fully vaccinated to travel, that helps motivate people. So we do have quite a lot of insight into people's reasons, and some people it's very difficult to persuade, but trying to give them the right information so they can make the choices for themselves.
Thank you. In terms of trying to get more information, have we done ward by ward tally to see which ward we lacking in terms of uptake, and make sure invest in those wards? Because if we know we can have a targeted campaign in those wards, and if we know the demographics or community groups that are not taking those vaccines, we can direct targeted measures in those areas.
Yeah, we have been doing that for quite a while during this period, actually, and we still have, although I was saying that a lot of our governance structures have now stood down, we do still have a very strong vaccination governance structure across Blmk and then at Luton Place. So there's a Blmk-wide strategic meeting, and then we have a Luton Place-based vaccination meeting, which was fortnightly and is now stepped down to monthly. But that meeting, every time they meet, they look at the ward maps, look at different age profiles, ethnicity profiles, and we know very well which ages have lower uptake, which wards have lower uptake, which ethnicities have lower uptake. And part of the whole point of the COVID Vaccination Champion Programme funding additionality is around targeting areas and groups of people that have lower uptake and getting that out to the community. So there's that community voices heard, and getting out to events and translating materials and keeping the motivation there to make sure that we're trying to get the right information to people and making it accessible to people. So we know that in the South Ward, Dallow, Biscot, all of the areas sort of relatively near here have lower uptake, and the mall is accessible. It's quite accessible for most of those wards to get to the town centre. So we're trying to promote that. When we did a while back now, we did we got some additional national support to do the door knocking. I don't know if you remember talking about it in this meeting, and that we very much focused in the wards that we knew had lower uptake. I mean, I can't say that had a big impact, but we are able to focus very much on areas that we know have lower uptake.
Thank you. About the vaccination and the various initiatives, you're saying that you weren't too sure whether the door knocking was having any effect. Is is there any way of collecting information about which of these initiatives are more effective or less effective?
Yeah, we did for that door knocking. We did a big evaluation piece actually, and there was an impact, but it wasn't kind of this big surge of additional uptake in those weeks that we were hoping it would. And then from January to March, we had a very focused inequalities plan that we've evaluated. I can bring the evaluation or circulate it to the group actually, if helpful. And some of it's not just you see it come through in the numbers, but some of it's a bit more qualitative or subtle than that, thinking about some of this really difficult outreach and the conversations that you're having that would have a knock-on effect, and you can't quite it's not so quantifiable, but we have been trying to evaluate and learn from things as we go as much as possible. I don't know, I just wonder if Nikki wants to come in at all as CCG leading on some of this from the NHS point of view, because obviously the public health are very involved in the programme and leading a lot of the work, but it's CCG led as well in terms of their role. So I don't know if Nikki, you had anything to add on anything. You're on mute.
Sorry, that was not very clever. Thank you ever so much, Sally. So, I mean, I think only to add to what you said, it's about working with the communities. I mean, you've mentioned previously that we still have a lower take up. I think everyone's aware that we've got the old post office in the Mall, and that is the plan to retain that. We're trying to make it a really what I call central hub, because we're doing identifying of people with potential to have their blood pressure checked, because we know we've got quite a low prevalence of hypertension. So I think really this members, councillors in this scrutiny meeting, it's how we all work together. And I think, Sally, you said there's still some people who are saying they're not as opposed. We just have to keep going and keep that open, what we call the evergreen offer. But any and Councillor Malik, any of those recommendations. So can I just say, Sally and Chair, that we had a national visit, was that Tuesday of last week, and we were really commended and that is us as a I would say a Luton system, and that's totally and utterly community faith leaders working with the community voluntary sector, and all the work that we've all been diligently doing. I just think it's just an ongoing cycle. I'm happy to take any questions if you think there's any more we could be doing.
So we've been commended for all the work we're doing, trying to get to reach all these difficult to reach groups. But so is that saying that it doesn't matter what we do?
Well, I think, Chair, the language that we're trying to use is underserved, because actually they're not hard to reach, is that we're just, whatever tactics we've got isn't working. So they're the underserved. So if you compare us with similar demographics, we are well ahead of the game. If you compare us within the Bedfordshire Luton Milton Keynes system, we're quite low. But Sally and I don't mind that, because it means that we need to have the additional resources to identify what is our hard to reach, our underserved, sorry, not hard to reach, our underserved populations. And that, for example, we know we've done some really good work with the homeless. We've done some really good work with the groups of people with serious mental illness. I think we're fairly exemplar with the groups of learning disability. So I think, Sally, if I'm correct, it's the targeted vulnerable we're doing exceptionally well on. It's probably the healthier part of the population that we haven't quite convinced yet. And that's probably because we've got a younger population compared to, to other areas. I don't know, Sally, what you think?
Yeah, I think it's a combination of factors, and I always think that it can be frustrating when we do all of this work and we're still really low down in the rankings. But I always think if we weren't doing all of this work, you never have that comparator of what would have happened if we'd done nothing. So I think we have done a lot, and we continue to learn from what we're doing. And even in the Vaccine Champions additional grant funding money that we've got, there's lessons learned, things that haven't worked so well, things that are working better. We've got some young people that are being trained as peer mentors for each other, you know, in a network of young people, a peer champion, sorry, which I've got hopes will be really helpful as well. And they interviewed me for a TikTok thing, which, you know, it's much more of a younger cohort thing, TikTok, isn't it? So we're trying and learning and doing things all the time and trying to get that evaluation clear, but it's not always easy to say exactly what works and what doesn't.
You're on mute again, Vicky.
Sorry, I'm on two screens. I'm on a different screen than normal. So the only other thing that I would just say, Chair, is that I think it was last week, we are still having people coming forward for their first ever COVID vaccination. So there is something about not giving up on people, because we know is that if we can get them 3 doses, first, second and a booster, you know, within the timelines, it will give them the protection. So I think equally what we've done is we've tried to do the school age immunisation. So although the numbers are quite small, we've managed to immunise some children with measles, mumps, rubella. Well, who knows if that actually reduces one brain damaged child. The numbers may not look great, but the impact's phenomenal. So I just think it's not losing morale and just cracking on.
Thank you. Yeah. Point taken about underserved rather than difficult to reach. Jeff.
Some time ago, there was talk of a combined vaccine with the flu vaccine. Do we know where we are with that? And the second part of the question is, have we established the longevity of the current vaccine?
So if I start that one, because only that I had the good fortune of being with the national team. So at this moment in time, we're told there are still plans to put the 2 vaccines into one, so combine them. I don't think, from what I heard, that it's likely to happen this autumn, but there will be a real commitment to desperately try and co-administer, i.e. to have the vaccine available for flu at the same time as COVID. And those of you that are very open, you know, that were close to it, you'll realise that was quite hard. There's absolutely no reason why they can't be done together. That's certainly what the scientists and the clinical advice is. So that's a one. The second point, Councillor Petts, your second question that you said was about how effective the vaccines are. Is that the question you were saying about what the duration is?
Yes, that's correct. Yeah.
Yeah, so at this moment in time, we're told there's very, very little benefit on having it done any more than 6 monthly. For those people who are clinically extremely vulnerable, they're the ones that we've actually given a further boost. So they may be 3 months. But as you know, the Committee of Joint Vaccinims are continuing that research. And Sally, correct me if I'm wrong, we're still only providing what we call the fourth one, the fourth vaccine, which is like the second booster to those people who are 75 years and over, or any age group who are clinically extremely vulnerable. That's the guidance.
Yeah, that's right. So that's the spring booster. So it's the 4th dose for those people.
Anyone else? Umi.
Thank you, Chair. I just had a quick question. The COVID cases are sort of rising, I think, in the east of England, and there's a note in here about it rising at the Luton and Dunstable. But it seems like in the NHS they're sort of easing restrictions, and staff aren't having to wear masks anymore. And I think that's going to probably have an effect. I know it's had an effect on where I work at Addenbrooke's, in that more staff are now off with COVID because there's still isolation rules, and we still don't want staff spreading COVID to vulnerable patients. So how prepared are we for that? Because it looks like cases are rising, and possibly more so because we're not testing. The cases are probably a bit higher than what we're thinking as well.
So I'll have a go at that. We're very much guided by the national and the regional teams. And yeah, everyone is aware it's probably the bank holiday celebrations. But at this moment in time, the hospitals are following the regional guidance, national guidance, which is about easing off and allowing, visiting and taking masks off. But it's a point well taken, and I don't know, Sally, whether you've got anything locally to add to that.
No, I think it's really difficult. I was talking to people earlier actually about should we be doing more now at this point, because it does seem like cases are starting to rise. But I think without national direction on that, there's very little additional measures that we can put in place at this point. I think in the hospital setting, yes, there's still more testing to protect people, which is good. But I don't think there's particular pressure in the hospital at the moment, but I'm not that close to all of that detail at the moment. But yeah, I think we just need to watch and wait a little bit and see what happens over the next period. I don't think there's any additional measures that locally we would want to be putting into place at this point.
And probably just to add to the assurance to the committee is that we review those daily through what is the clinical commissioning group. We still have our daily check-ins. So although the numbers of COVID within the L&D site had increased with that bank holiday weekend, people were in with something else. It's just they've been tested and they happen to have COVID, which I think is really important. And I checked the figures and I am not aware that there's anyone who is unwell, as in needing ventilation. So it is, as Sally said, we're not testing out in the community. It's just that in hospitals, people are being tested. So again, it is that watchful wait, but it's a point well taken, well made.
Steve?
Just on that subject then, when you mentioned earlier that you had 2 people, was it in the last week, 2 people who had died with COVID? Is those 2 people that had died and happened to have COVID, or 2 people where the one of, if not the primary cause, was COVID?
I need to double check that actually, but I'm pretty sure it's with rather than from.
Okay. Thank you, Sally and Nikki. I think it's an important point you made about we don't know what would have happened if we hadn't done all this rolled out all these initiatives and actions to increase the vaccination uptake. The proposal is that this update report comes to this group by exception rather than every meeting. I'm happy with that, with the proviso that if the numbers do start to uptick, then perhaps we will require an update at the next meeting. If that's okay with the group.
Okay.
Thank you.
Thank you.
Numbers rised.
Yeah.
Okay.
Yeah. Good point, Steve. Thank you. Okay. Thank you. We move on to the next item, the Mount Vernon Cancer Centre Strategic Review. Can you introduce yourself first? I think that'd be a good idea.
Yeah. Thank you. So, hello everyone, and thank you for having me here. My name is Jessamy Kinghorn. I'm the head of partnerships and engagement for NHS England in the east of England. And it's my first time here, so I'm very delighted to be here. And thank you for asking me to present on this subject, which is the Mount Vernon Cancer Centre. NHS England commissions specialised cancer services, which is why we're here to talk about it. In Luton, if you have a suspected cancer, you're likely to be referred to the Luton and Dunstable Hospital for a diagnosis. And if that's confirmed, your specialist cancer care is most likely to be provided by the Mount Vernon Cancer Centre. Much of that, so the chemotherapy and the immunotherapy, can take place at the Luton and Dunstable Hospital with a Mount Vernon oncologist. But the more complex oncology treatments, the specialist trials and the radiotherapy, for example, take place at Mount Vernon Cancer Centre. Now, I'm not going to go through the whole paper because there's a lot of information in it, but that Mount Vernon Cancer Centre is in Northwood, in northwest London. It serves a really big population, of which Luton is towards the north. It's not the northmost point of it. And around 600 patients a year are treated from Luton, are treated at the centre. So those are patients whose care is physically at the centre, not just those who are under the care of the Mount Vernon team. That makes up about 5% of all of the cancer centre. Bedfordshire as a whole makes up 11%. So it's a reasonably sized piece of the whole of the cancer centre's activity. The reason why I wanted to come and talk to you about it is because we do need to make some changes. We've been working over the last couple of years in response to an independent clinical review that said that changes were needed. We've been working with Hertfordshire Health Scrutiny Committee and Hillingdon Health Scrutiny Committee. Hertfordshire as the largest the largest number of patients are from Hertfordshire, and Hillingdon as the scrutiny committee for where it is currently located. And I think we've come to the conclusion that we will need to move towards having a joint scrutiny of some description to oversee this project going forward. We need to make changes for three main reasons. The clinical team that we brought in was on as a result of some clinicians coming to us and saying they had some concerns about how sustainable the services were in the long term. And we brought in an independent team from a different area of the country entirely. So it was from the Christie up in Manchester and Clatterbridge in Liverpool. And they said that some urgent changes were needed. And the changes fall into three main categories. So firstly, there were some immediate changes, some short-term changes that we needed to put in place. And that included the appointment of some additional staff. And it also included restricting admissions. So there were a lot of transfers happening of people whose care deteriorated at Mount Vernon because there weren't the right clinical support facilities on the site, and they would be transferred to another hospital, which meant their care was very fragmented. So as a result, fewer patients are now admitted. They're admitted to another hospital in the first place, so that there won't be those more urgent transfers of care. A more medium term, if you like, recommendation was that the centre should be run by a specialist cancer hospital, not by a local district general hospital. So we went through a process, open process, and appointed UCLH as the preferred provider of the service in the future. And we're going through a piece of work with them to really make sure everyone fully understands all of that before that transfer happens. And one of the things that transfer is dependent on is having a solution to the third set of recommendations, which are the long-term recommendations, which are that the cancer centre cannot continue where it is on a site that has no other acute services on it. It needs to be moved onto an acute hospital site. We've done a big piece of work. We've involved lots of patients in that, members of the public, and identified Watford General Hospital as the most appropriate site for moving the cancer centre. UCLH, as the potential provider of that service, have submitted an expression of interest to the new hospitals programme to fund that. We are still waiting for the outcome of that. All of this is really dependent on getting some funding, some capital funding, to be able to make the changes. We are very mindful, though, that even moving the centre to Watford would make a slight difference to people from the north of the patch, but not a massive difference. People living in Luton and Bedfordshire and the sort of northeast of Hertfordshire have very, very long journey times. And if you are having radiotherapy treatment, you could be travelling every day for 6 weeks, for example. And we have heard stories from those areas of patients who have declined treatment or opted for a different type of treatment because it's just too much for them or too difficult to get to. We're also mindful that in Luton, cancer outcomes are not as good as they are elsewhere on the Mount Vernon patch, elsewhere in the country. And this has to be an opportunity for us to be able to make improvements to cancer outcomes rather than just relocating a building. So we've been working with the clinicians and with some patients to look at the model of care that we'd like to do. And one of the a couple of things we'd like to do is increase the amount of chemotherapy that happens locally and be able to provide more care closer to where people live, so it's easier for people to get to. And for radiotherapy, the preferred model, the preferred option that we'd like to go with, if we can fund it, is to have a networked radiotherapy unit in either Luton or in Stevenage. Both hospitals meet the clinical criteria, both have the space, both are willing and keen to have the radiotherapy units at their site. It would be run by the Mount Vernon team from the new centre. And the idea of that is that it improves access for people who live in those areas. We can only have it in one place or the other. We're going through a process at the moment to determine what the criteria should be around selecting that. And that will be part of the public consultation that I'm expecting we will need to have on this proposal. We won't be getting to public consultation until the funding route is identified. But that's where we're wanting to go with it. So I wanted to bring it here really because I wanted to make sure that you were aware, and there's a long way to go with it still. But thank you for inviting me here to at least give you some of the background. So thank you.
Thank you. Yes, thanks for taking the time to come here and present the report. Gilbert.
Chair. Thank you very much for listening. I am a cancer patient. In 2012, I did all my radiotherapy 21 in Mount Vernon. I had my chemo at Luton and Dunstable. Now, I know Mount Vernon like the back of my hand. Before I got married in 71, my wife worked there. It was a burns unit. It is now saved my life. And this happened in 2012. We're now 10 years. Now, to move it to Watford, I've been to Watford Hospital. My grandson had an operation there. A lot of Hemel Hempstead Hospital was moved to Watford Hospital. The roads around to Watford Hospital is not the easiest roads. It's near the football ground. Parking there is a bit of a nightmare because I've been there. To then put a specialist cancer unit next door incorporated in the Watford Hospital, it could get swallowed up and we'll lose all the ability to treat people with cancer. This is my opinion because I've been through it, right? 21 radiotherapy, 12 tablets to be swallowed an hour before, mask, everything. The people at Mount Vernon was absolutely fantastic. I've seen people in the wards having chemo, they wheel them down in their beds for radiotherapy at the same time. And as I said, Watford is getting, as I said, a lot of Hemel Hempsteaders moved into Watford, and now you want to put a specialist unit to be swallowed up by Watford General Hospital, where I know Mount Vernon is an old hospital, right? But to then put it in with Watford Hospital, I think it could be a major mistake. We need the cancer unit, if it's necessary, spend the money, build a new place in Mount Vernon, because I used to drive myself M1, M25 through Rickmansworth straight into Mount Vernon. It didn't take me that long. But Watford, I've been to that hospital. It's a nightmare to go through those little narrow roads, right? So you are telling me M1, M25, yes, by when you're at Rickmansworth, it's a little bit big. But I think there's a heart hospital nearby as well. So I am afraid that this sounds fantastic, but I think it's going to be a major disaster. I know there's new different radiotherapy coming on board and stream and all that, right? But let's keep it separate from the main general. Yes, chemo is in Luton and Dunstable. I've had it there, right? But the specialist treatment I see at Mount Vernon is unbelievable. We had a bloke there, he used to feed himself through his tube and everything because he had mouth cancer and all that. And we used to sit there, it's a family. It's a family down there. And to move it into Watford, I think is going to be one of the biggest. We need to really think properly. I've been trying to get hold of Dean Russell since this come up, and they've been ignored. And as I say, 10 years. I'm here because of Mount Vernon. I don't think it's going to get better putting it amongst Watford when most of Emma Lamsdale Hospital is moved into Watford and God knows what else. Stevenage, they do chemotherapy over there. Because I know someone who's having chemotherapy over there. But please, let's keep it as a specialist one hospital, because cancer is a big, big problem in this country. And to then get it swallowed up in Watford General Hospital, I think, big mistake. Thank you, Chair.
I can give you some reassurance on some of that. So the proposal isn't that it's part of Watford Hospital, it's on the site. We'll come back to travel. I recognise the challenges around travel around Watford. But just to be really clear, this is a specialist standalone cancer centre in its own building run by UCLH, who are the specialists on a site. The reason it needs to be on a site like Watford is because we need to make sure that we have got immediate access to critical care, to a whole list of medical services which are not on the site at Mount Vernon. Going back many, many years, you mentioned burns. There was a whole load of other services on that site when Mount Vernon Cancer Centre first was there. Those over time have been stripped away. They're all part of the London system. They are no longer there on that site. And Hillingdon Hospital, who owns the site, their plan is to consolidate all of their acute services, so their main hospital services, on their Hillingdon Hospital site. Watford is the closest acute hospital site to the current Mount Vernon site. So if we're going to move it anywhere, what we want to do, we've heard repeatedly how well the staff have done, how valued the staff are, and so one of the benefits of moving it to a close hospital site, as it were, is the likelihood of keeping the team together as the same team that are providing cancer care now, providing it in the new hospital, is much higher, and so keeping that family feeling. But it would be its own cancer centre. It wouldn't be sort of swallowed up as bits within Watford Hospital. There would be a bridge between the cancer centre and the hospital, so that if a patient deteriorated and needed to be moved into a critical care unit, they could just be taken across there. In terms of transport, in Watford, they have opened a new arterial road at the back, which is a dual carriageway that runs right up to the back of the hospital. From personal experience, I can say that's made a massive difference. It doesn't completely eliminate the problem. We accept that. There is a transport group that's been set up and a lot of discussions going on around both for the Watford Hospital itself with their redevelopment plans around how we can improve access and make it easier for people to get there. But when we get to talking about Mount Vernon moving onto the site as well, we'll need routes into Mount Vernon from further away than Watford needs for its day-to-day business. And so making sure that those are working effectively as well. There's a long way to go, as I said. We looked at every acute hospital site in the Mount Vernon area. So that included Hillingdon, it included Northwick Park, it included Lister Hospital, it included Stoke Mandeville, Wexham Park. We're talking about a big area. It included Bedford Hospital, Luton, Dunstable Hospital. Watford is the only one that has all of the right clinical facilities and has the minimal impact on patient travelling times, meets the requirements that we set for travel and for public transport. Mount Vernon, so the other ones that came close were Hillingdon and Northwick Park, both of which would have moved the Luton population further into London. So that wasn't acceptable to the East of England commissioning team. Luton probably came in next, as it were, Luton and Dunstable Hospital, but that wasn't acceptable to the London team for the patients from London. So it's a really tricky one, because in an ideal world, you would have a specialist cancer centre that was easy access from everywhere, but the population that we're serving is well over 2 million. So we are very mindful of some of the travelling issues around Watford. I think we heard that when we were doing the work initially. We heard that for every hospital site. We've been doing a lot more focused work specifically on Watford since it was identified as the preferred site. At the moment, we don't think that any of the other hospital sites offer a better alternative. So we're looking at mitigating some of the difficulties with having a network radiotherapy unit, which, as I say, would either be at Luton or at Stevenage. We need to go through the right process. I'm sure people in this room will have a very strong view in one direction. I could sit in another town hall and have the opposite view. So we need to go through the right process and identify which site is going to really have the best impact overall for the population. But I do hear your concerns. I'm glad that you had good treatment. I'm glad that you're here. Yeah, it's a really tricky one. If somebody can, solve the transport issue, I think we'd all be very happy. But we do need to move it onto an acute hospital site. I think the services are simply not sustainable if they're not on an acute site.
Thank you. Sally?
Thank you. I just wondered, you were talking about the additional radiotherapy treatment option at either the L&D or Stevenage. What's the criteria that you're looking at to make that decision? And does the disproportionately poor cancer outcomes in Luton have a say in that decision-making process?
Yeah, that's a really good question. Yes is the short answer. We have gone through a whole range of criteria. We've had a number of people involved, a number of organisations involved in looking at what the criteria should be and what the weighting of those criteria should be, so we can rank them in order of importance. And that's included a patient reference group. That patient reference group has had membership from Luton and from other parts of the area. And absolutely, it includes things like, does it meet the national criteria for a network radiotherapy unit? So the safety and the quality issues, are they there? Is it one of the criteria is around access for patients? There is a criteria that's specifically around equality and inequalities in particular. And there's some measures. I don't have it in front of me, but I could certainly let you know what that is. But that does feature in there.
So what's the process for that decision then, in terms of the timeline?
So at the moment, because it's all subject to capital anyway. It's the timeline's a little bit up in the air at the moment, if I'm completely frank. The final decision on whether it would be Luton or Stevenage will be following a public consultation. We are in the process of looking at what the questions would need to be in that public consultation, and any views on that I would welcome. I personally am not a big fan of should it be this one or that one, because I think all that does is have people sort of vote by where they live rather than thinking through some of the issues. So I really would like some questions that tease out some of the issues and some of the challenges, and that will feed into a decision-making process that would follow that consultation. I'd like to be able to give you a date for public consultation, but that depends on knowing that we've got the money that we need to build the cancer centre.
Thank you. Thank you for the update. I think some of my questions I had in mind, notwithstanding what my colleague, Councillor, said about how treatment is excellent in Mount Vernon. I think any review to improve oncology services for people of Luton is really welcome. And I think if this is going to save lives, we should do that. My question then is about, I think Sally picked on it, it's about the capital funding and timelines. How long are we talking about? 5 years, 10 years, 20 years? I think we need something to tell us, okay, within this time, we are hoping that this would happen. I haven't seen anything here. The second question is to do about the JHOSC, how it's going to work, because we used to be part of JHOSC, took a political decision not to be part, how that is going to be integrated into this. The third question is, as you know, the language used here is to do with CCGs and staff. From 1st of July, abolished, we are going to ICS. How does this fit into the future in terms of ICS going forward? How is the funding and everything fits in? I would like to know. Thank you.
Okay, so I'll try and go through all of those. So in terms of the timeline, which I think was the first question in that, at the moment, the expression of interest that was submitted on the guidance page, it says that the decision will be spring 2022. So we're awaiting a decision. A decision is imminent. If we are on that list and we can start the ball rolling, that for us is enough confidence that we can go to public consultation and we can make the decision on what we need to do. If we're not on that list, then we still need to go through continue looking at where can we get the funding from. That's the really crunchy issue. If funding wasn't an issue, if somebody wrote me a check for everything that we need, we could go out to public consultation. We could, assuming that the public consultation was supported with, we've maybe tweaked the proposal a little bit, but in general was supported. We could actually start things in a phased way, or we could start things all at once. So, for example, we could build a network radiotherapy unit ahead of the main cancer centre potentially. Building the main cancer, we're not talking about a full district general hospital scale. It's smaller than that, but it would still take a few years. So if we got the go ahead next week, for example, we could potentially be talking about 2027, 28 opening, I would think. I know that things are always very challenged in NHS and public sector building terms, but I think realistically we're talking about 5 years. In terms of sustaining the services on the site, we do have a lot of support on the site at the moment to make sure that we can continue to provide services. There are some services that the site no longer provides, so it does not provide haematology inpatients anymore, and from the summer it will not be able to provide haematology outpatient either. That means for patients living in Luton that they are travelling into London for their treatment for haematology. So we want to get things moving so that we can sort that out as soon as we can. But we need to make sure that the services can be provided, the right clinical environment. And it's not the physical environment, it's the support facilities are there for them. We need, for the sake of the clinical teams as well, they need some certainty about what's going to happen. So we're hoping that a decision can be made reasonably, in the next 12 months, and then a new build would be within 5 years or so. It is very much dependent on having the money to do this. You asked a question about a joint HOSC. I've had a few conversations with Natalie Rotherham over at Hertfordshire HOSC about how this could work. I think we need to do some more work. We did talk about having a meeting of interested members from across. There's about 14 HOSCs potentially who will all feed into Mount Vernon. I've never been involved in a joint HOSC that big. So I think what we thought we'd have initially is a workshop to discuss with members how they felt it could work effectively and what the best way forward would be. But nothing's been finalised at the moment. In terms of CCGs and ICSs, absolutely. We have had ICS representatives on our programme board for some time because we knew this was the direction of travel. We use CCG, and we will continue to refer to CCGs in the paper, in I think the areas that you've noticed, because that is what the data refers to. So the data was collected. We could aggregate it up, and I could say for Blmk this is the number, but actually for you it's more meaningful, I think, to have actually this is the Luton population, because this is based on our activity information, based on our costings, our what we pay the providers for their treatment. It's done by CCG, and because of the years that we've used, it will continue to be done by CCG because that's how it was calculated at the time. But ICSs are very much involved in the decision making. They're sat around the table. We have a joint commissioning committee with NHS England and with the ICS, each of the 6 ICSs in the East of England that will be represented and will be seeing this through. And just on the data, the reason that we've used 2017 to 2020 is once we hit 2020 to 2021, the figures are really quite severely impacted by the pandemic. And if we want to plan a service that is the right size to treat the population, we don't think that those figures are reflective of the actual cancer need of the population. I know there was a lot of a dip in patient attendance at appointments, because even though for Mount Vernon it was managed to keep itself sort of COVID safe, as it were. We need to really look at the data again, and we're starting to build up a picture now going forward of what that looks like. But that's why the data might seem a little bit old, and that's why we're referring to it as CCG data. But in terms of what I think you were actually really getting at, absolutely, ICSs are completely round the table.
Thank you. Anyone else?
Is this just a very short question? It's thank you for presentation. And is this a consultation, or is this just making a way?
This is making you aware of it at the moment. My strong view is that this will need to go to a formal public consultation, at which point obviously we will come back. But I didn't want that to be a surprise when it happens. I wanted you to be kind of aware of the work that's going on. I think we've done enough work now, and we're far enough down the line. We know what our preferred option is, and we have been working very closely with the HOSCs that have the larger number of patients, but I felt it was about time that we kind of went a little bit wider, and you were cited on it as well. So an informal involvement and engagement with you, but a consultation to come.
No, my thinking is there is no alternative at the moment on the card.
Yeah. That makes it very tricky with a consultation, doesn't it? We will be going to consultation with a preferred option. And I think we'll be very, very clear with the public about what they can and can't influence and what we're asking. We may not be asking, should we do this or shouldn't we? We may be asking, how can we do this? Or how, we need to move this. This is the preferred option. These are the things that we are putting in place to make it easier for you. And might be asking more about those solutions, and that might be network radiotherapy, it might be chemotherapy, and other options. As I say, we're beginning the process of thinking through what those questions should be. It is very tricky. It's much easier to say, shall we have it here or there? Yeah, I think we weren't necessarily expecting to get down to just one option, but when we looked at all of the travelling times and so on, it was fairly clear that there was only one. And if there wasn't just one, it would have been 3, and it would have been Hillingdon and Northwick Park as well, which I just don't think would have been acceptable to the north of the patch. And it was the north of the patch that had the poorest outcomes and the longest travelling times. So the programme board, I don't think, even London, the London region, in all good conscience, they were the first, I think, to say it needs to not be in one of the London hospitals. It needs to be in the Watford option. But equally, I don't think they would have gone for any further. So I think we'll go to consultation on a preferred option with perhaps some variables, and that might be where we start asking the question. But yeah, it's a good point.
Thank you. Jeff.
Thank you. I'm a volunteer driver with Keach Hospice, and when you pick patients up, a lot of them wanted to chat with you, and I'm astounded at the number of patients that they say they've been misdiagnosed for cancer. Our current crop of doctors coming through, are we not training them to recognise cancer? Or is it just that there's more cancers, about different types of cancers about? And I appreciate it's sometimes difficult to recognise these things. It must be. But what do you know what's happening? And is this proposal that we've got here in front of us going to help?
So I think this proposal is very much about the secondary part of it, the specialist end. So this is after you've been diagnosed. This is the being treated. But we've been working really closely with Bedford, Luton, Milton Keynes ICS. And there's been a piece of work that we've been very involved with, looking at Luton outcomes, that's come up with a whole host of recommendations. There's a summary attached at the end of the paper, more relating to how it affects to the Mount Vernon Cancer Centre, but there is a lot of work going on in primary care and in other areas to try and improve access and improve outcomes. There's been some funding that's been donated by Macmillan to fund some, I'm going to get the title wrong, but some community champions to work with people in the community to make sure that they are getting to the right services and they're being signposted in the right way, and to support people through that, what is very complicated pathway. I can't answer your question directly, but I know that colleagues at the ICS are doing that work, and I'm sure would be happy to provide you with some information.
Can I just sorry, can I just wanted to make a quick point. Sorry, I was jumping in just to make a quick point on the community navigate. I can't remember. No, they're not navigators. The community champions. They will be for Luton based in the public health team. So we're out to recruitment for those at the moment. So we're very much linked in from the public health perspective and making sure that we're looking at inequalities and how we can make the most of those roles. Sorry to jump in, Chair.
Thanks, Chair. As my colleague here said, what we need to move forward rather than treating is to catch the cancer early. Fortunately, I think mine was catch early. Now, while I was at Mount Vernon, the amount of prostate cancer patient I saw there was unbelievable because it's not been catch early enough. people, it's now people 40 or probably even less is having prostate cancer. And really and truly, we need to channel some of that into diagnose. Is that correct? So, especially prostate for men.
Okay, if there's nothing else. Oh, sorry, Nikki, you have your hand up.
I was going to add a little bit to what Sally was saying. Is on the next paper, which actually on the pack of papers on page 26, it does actually have the outcomes of the cancer board. So being primary care, I'm exceptionally close to early diagnosis and indeed screening. So that is what, and I know Mark's on the call as well, but Mark, Sally, myself doing with the Luton Place Board, because that's about how we work with our communities, because we know that our take up of screening is low. So the where we should be working is totally at that front end. And again, if you have a look at page 28 of the papers, it talks about the different work streams, which all interface. But I just wanted to make that point because prevention needs to be absolutely forefront of everything we think about and do.
Okay, thank you. Thank you for coming on tonight.
That's a pleasure. As I said, in an ideal world, we'll get there at prevention and nobody will have a need for a specialist cancer centre. But whilst we do, let's make sure we've got the right facilities in the right place and we can really help improve people's cancer outcomes.
Okay.
Absolutely.
I think it'd be a good idea if you could come back to report to us when the public consultation is underway and if and when the funding's available. Okay. Thank you. Okay, next item is update on the Blmk integrated care system. Nikki.
Thank you, Chair. I'm going to take you just through the paper, but hopefully everyone's had a chance to have a scan through. So just put the context is that Health and Care Act 2022 completed its passage through Parliament, as we all know, because we talked about that last time in April. So we are absolutely all set to commence from the 1st of July. I think it's really important to note that this is a very different system. This is all about how we are working in Bedfordshire, Luton, Milton Keynes. And I know, Chair, we talked about this previously, because the Luton system has got the legacy of absolutely partnership working. And I think, in fairness, as part of the preparation work that we've had to submit to regions and the national teams, is that the Luton Place has got all the right ingredients and it's got the right relationships to go forward. So we're in a very good place, and I've used this terminology before, but just to decipher it, this principle of subsidiarity, it's basically making the decisions as close to the populations we serve. So we have a very good track record of that. So I just want to be, and you, hopefully colleagues are aware, but your members, and I'll just check. So you've got Councillor Malik, Councillor Hussain and Hazel, obviously leader of the council, who are members of that integrated care, the partnership board. And I think I saw it communicated about 2 or 3 weeks ago, is that the chair designate of the ICP, the Integrated Care Partnership, is Councillor Tracy Stock, who is from Central Bedfordshire, and that has been jointly agreed by Luton and Central Bedfordshire and Bedford Borough and indeed Milton Keynes. So just taking through that this has been, you know, co-designed, co-produced, and I know people have been working together, pulling to those terms of reference. You're all aware that Dr. Rima Makaram is the current chair designate, the current independent chair of the ICS. and the chair designate of the ICB. And Felicity Cox, and I think you've all met her, is the will be the chief exec designate of the ICB. So we have got some continuity of relationships because Rima and Felicity have been in the system for a period of time now. So we have to produce a 5-year integrated plan that will embed the principles of population health management. Now, I know Sally in previous meetings has gone through about the inequalities and the amount of healthy years lost with communities, and Luton does come up as an area where we need to invest to manage those inequalities. So there are a number of slides. I'm not proposing to go through the slide pack but they are very much there as an aid memoir because they're an easy version of what I'm describing. But what I think is important for colleagues in this meeting to be aware of is that the health and wellbeing boards are the link to the integrated care partnerships. And we talk about the you probably see it in the newspapers about the ICB, the Integrated Care Board. In effect, that you could argue that's the engine room. That's the part that will manage the NHS budgets and be accountable for all of that budget. And it's well over £1 billion. So we're talking really considerable amounts of public taxpayers' money. But the most important thing is how we work with that Integrated Care Partnership Board, which is, as I say, the board that actually sets the strategy. The Integrated Care Board does the delivery. And we have talked again previously about the Luton Place Board, because that's absolutely key to all of this system working. So it's the place boards that will be accountable to the health and wellbeing boards. So that's all Luton, and you've all got autonomy and control there. And it's how the health and wellbeing boards interface with that integrated care partnership. So hopefully the diagram on slide 2 and also in those slides that we've sent you helps to demonstrate that interface, because it is confusing if you can use those acronyms. So afterwards I'll pick up any questions, because I know that I've gone through this with other colleagues and some of the Health Watch, and it just needs to be discussed a couple of times to get some clarity of all these acronyms. So the Luton Place Board, you can see in section 8, the Health and Care Act absolutely recognised place. So that's very good. In our Blmk system, we've got the Luton Place, the Bedfordshire Place, the Central Bedfordshire, and Milton Keynes. So the set of strategic system priorities, which we have 5, and very co-align with what the Luton priorities, the start well, the live well, the age well, and about growth in the economy, and most importantly about addressing those inequalities. So they're the strategic priorities that have been co-designed with all partners in the Integrated Care Partnership. And I know we previously in previous meetings, Sally in particular, as the Director of Public Health, has talked through the population health management approaches. So that is using what we've been doing in Luton. So in effect, it is that continuation. It's not starting something completely from scratch. So we have included the role of scrutiny in the integrated care system because NHSEI and the Local Government Association have published that guidance. So, and that link is there for yourselves. So going back to the start of, almost why have we ever had these integrated care partnerships and the new ICBs? It is about addressing that inequality, and we know through COVID that has extended it, and we've seen it very, starkly in Luton. It is about improving health outcomes, and that's why previously when I made that comment about prevention, that needs to be embedded in everything that we do. It is also about improving the patient's experience and particularly access, and most importantly, how we're using the taxpayers' money. So it's all about how we work smarter. So we've given you some of those 6 strategic elements, which again, I'll take any comments if people want to talk through. So as I say, you've got the slide deck, which I would encourage, and if we can get that separated in from this set of papers tonight, I think that's something I'd encourage councillors and anyone else to use, because it's, I think, we think the 15 slides help to, you know, share that message of really who we are, what we're trying to do, and most importantly, you know, what difference it's going to make. The only one I'm going to relay on or talk about which is on slide 8, which is 44 of your pack, is Mary's story, because I think if we have a patient story, it just brings some of all this, you know, what can be jargon to life. So 89-year-old Mary is admitted hospital following a fall. She's lived on her own, she's managed quite well, mild dementia, but able to live in her own home, and type 2 diabetes, but is feeling isolated. So what we know from the past, and I think Luton, we've been a better place than others, but even in Luton, we know that there's fragmentation. So in the new way is that the longer Mary stays in hospital, the more she deteriorates. We talk about decompensation. So you know, we need to get her home as quickly as possible. So to get her home, you need the packages of care that often include nursing care, you know, maybe for wound dressing, but most importantly, some therapies. Could be physio to get her mobility, and the additional care to get her eating, drinking, and feeling, you know, having a bit more self-confidence, managing diabetes, etc. So the new way of working is to have a team, and it doesn't matter, you know, whether you're working with the mental health trust, the community trust, the social work team, you know, it's one team coordinating that care. And it's all about personalisation and what's important to Mary, and equally what's important to Mary's family if there's family. So you really try and use the assets around Mary to give her, you know, the best possible chance of getting home and getting that social interaction, and keeping her safe and basically making her life better. Similarly, we're just giving you another patient story of a younger person, Helen, 28, and, you know, these are fictitious stories, but they're based on scenarios that our clinicians have come forward with. So a 28-year-old mum, 3 children, referred to the local mental health services. When you get to the bottom of it, you find that she's experienced some physical, mental, sexual assault from a partner. She's got 3 children living in cramped accommodation, 2-bedroom flat, and she's suffering with depression and low self-esteem, and is beginning to self-harm. So again, it's that same ethos of what I've just mentioned on the previous. If Helen has one team coordinating, that may be about working with the local council, maybe the schools, because the children's behaviour may be being affected. That may be causing her stress. So working with school, family practice. You know, maybe the benefits agency, could be a whole host of people, but actually working together to give that coordinated approach. So they're just a couple of patient stories to give you an illustration of working together to make the lives of our residents, you know, happier and more fulfilling. So happy to take any questions, Chair.
Thank you. Anyone? David.
Thank you, Chair. Thank you, and congratulations on your appointment, Nikki. It's good to see local people gain positions in there, and we can rely on you to make sure Luton is best place for this. I've read the document. The only thing missing here is funding. I haven't seen anything about funding in here. As we all know, we said the NHS needs money, and how this is going to be funded it's not said anywhere here. So that's a question number 1. We want to see how this is going to be funded. My understanding is ICS, ICP, IBB are supposed to break even. I'm not sure how that is going to happen, what that means. If you can explain to us how we intend to break even if some of us haven't seen how the finance is going to work. There's a concern about, again, how governance is going to work. I'm not sure whether you heard earlier on when you talked about in Luton Place, the Health and Wellbeing Board is going to be responsible. I'm sure my colleague on the other side, Gilbert, will have something to say about that. When you mention about the board is a consultative forum, I think some will say, is that a talking shop? That's what my colleague was trying to infer. So how can you assure us that the consultative forum is not going to be just a talking shop? How money from the NHS is not being moved into administration instead of frontline services to be provided? We've just talked about cancer provisions and stuff and diagnosis. I think most people will be saying the money for administration should be diverted to frontline staff. So I'm sure you're going to have a better explanation than what I've said or people are telling me. So please, if you can tell us about the finance, how all this is going to work, how much is being used for administration, and previously, how much is being used? Have we done any compare and contrast? Are we in deficit going into the ICS? If we are, how is that going to affect us? So that's my questions for now. Thank you, Chair.
Okay, I'll have a go, but at a high level. So what we have at the moment is the clinical commissioning groups, which are in effect GP membership organisations. So the functions of the CCGs will move into the integrated care system. OK, so let's just get the acronyms, David. So the integrated care system is the totality. The integrated care partnership, what's the ICP, is a statutory committee that actually sets the strategy for the population. So believe me, this is not a talking shop. So the chair of that is Councillor Stock. So that committee has absolutely, it's not a talking shop, it has a power base. So being quite clear, if I just explain what the ICB, the Integrated Care Board is, so that's the legal organisation reporting to what we have as national, NHS EI. So, but that Integrated Care Board will be accountable to deliver the integrated care strategy that the Integrated Care Partnership have agreed. Do you understand what I'm saying? So the Integrated Care Board answers to the Integrated Care Partnership in the sense of delivering that strategy. So it is the Integrated Care Board that, and Felicity as the designate chief executive and Rima as the designate chair, will be accountable with the director of finance and that total board of the finances and the quality and the operational performance. But you're absolutely right. So you're fully aware that NHS funding changed slightly because of the pandemic. So I'm just going to give you a sort of layman's language for me. It's almost that the region have agreed set budgets based on with COVID. So as far as money, there's no change of money, David, is that contracts. So if I just keep it to Luton, the contracts that we've agreed with the hospitals for delivering cancer services, for delivering all the acute services, the contracts for ambulances, the contracts with primary care for primary medical services, they're not going to change on the 1st of July. But what we do know, and the evidence suggests, is that we should, by working collaboratively, and if I again just keep it at Luton, so Mark, myself, Sally, yourselves, how we're working as a system, it should be about the Luton pound making a difference to the Luton population. So there is hopefully that way of collaboration, some efficiencies to achieve. Does that actually make sense? So there is no actual change of finances, but believe me that the Integrated Care Board, I had this question from somebody, I think it may have been in a different scrutiny meeting. Will the Integrated Care Board be in public? Yes, they will be. They're not going to be public meetings, but they're going to be meetings in public. So you will see what the budgets are and how the Integrated Care Board are delivering on those, including, and I do say, because the golden strand in all of this is quality. So it's finance and quality are the two that go together. Does that answer sufficiently, David?
Yeah, it does, but we want to know how much money or funding we have now so that we can be monitoring in terms of governance. So how much is spent on administration now? Do we know?
We absolutely do, because but the thing is, when you use the word administration, it's quite a loaded question. So if you're talking, for example, you may have heard this before, that we used to have a running cost allowance from the clinical commissioning groups, and we used to have to, I can't remember off the top of my head what the figures were, but we had to live within the means of the running cost allowance, and that was something that was set nationally. So, David, we absolutely have all that. So it's probably easier if I go back to the team, my colleague Dean Westcott, and we can certainly give you, because we've provided that for the various other reports, we can give you a rundown so you can have a look, and then happy to have a offline conversation so you're clear that you get the information that you're asking.
The second question is about the deficit. Currently, is the Blmk in deficit going into ICS? If it is, how are we going to break even? Because those are the questions people asking. All these issues, we should have left the NHS to deal with that. The ICB, my understanding, I'm happy to be corrected, is the NHS arm. The ICP then has become like a big administrative body where they're bringing more and more people to be paid, where people will rather the money is invested in frontline services. So we need to know, are we going into this ICS in deficit? And if you are in deficit, where are we going to find the money from? We need to see it in black and white so that we can monitor. As of now, yes, you've given the undertaking that we will say it, but when? Because the public will want to know. The cynics out there are saying this is where the NHS is being prepared for privatization and marketization. I hope it's not. So how can you assure the public that this process is not the start of marketization and privatization of our NHS?
So I'm probably, if I'm honest, not the most qualified person to answer this, but I will give you a go, and I will, as I say, have that conversation and perhaps get someone from the finance team. So being quite clear, the health budget isn't being blurred into one big pot in this integrated care partnership. So let me keep it really clear to Luton. So at the moment, within the Luton system, Mark and myself use something called a Section 75 agreement to where we want to work together and we want to have joint funding. So we have something called the Better Care Fund that I know you've looked at before. So we're absolutely clear when we pull money together and when money's joint. So from that basis, there will be, when I share with the finance information, you will be able to see there is no blurring. There's absolute accountability in the same way. What we do know is that where, for example, we work smartly together, so we've been this evening talking about cancer, we know where we work together to try and get our residents to access screening and for early diagnosis, that there is the evidence that if we do more prevention work and working with the communities, we will reduce the poor outcomes and the instance of cancers being diagnosed at a later stage of the disease, which you get but worse outcomes and it's more expensive. So I think for me, as far as deficit goes, COVID of the last 2 years has been a bit of a game changer for the way the health service, ever would have understood. So I know that we had to submit a plan for the Bedfordshire Luton Milton Keynes. integrated care partnerships. So that has gone in. So my understanding, but I will get finance to confirm that we are not going into this with a deficit, as I know we had in previous iterations when we had other boards. So I'm fairly confident that is the case. But it's fair to say, and anyone who isn't aware of this, you know, it's been in the papers, is that things are very tight in the public sector. You know, we know inflation, so that's probably the first thing that we know it's going to have absolute impact on our budgets. So I am not sitting here saying that there's, you know, a whole slug of money and we've got no concerns. It will be a very, very, you know, tough couple of years and going ahead. But we believe working together, and most importantly, using the assets that we have in our communities, that will make the best outcome possible. Again, David, I probably need to take it off because some of the questions you're asking are quite specific.
Thank you. Okay, so time's getting on, so I'm going to allow one more question. Gilbert?
It's not so much a question as a comment, Chair. You were talking about Mary's story.
Yep. Yeah.
I can tell you that is true. I've been involved in the care sector since 1985, and I've actually seen it. And what I've found over the years, the bureaucratic system has taken over, and we've lost the impetus of, if I'm using the right word, to think of the care of that person. I've seen it. 1985, I was involved in a care home, and the documentation was very small. By the time it ended, it was 132 different documents. I've seen the CQC inspector sit for 10 hours reading and writing and never even spoke to one of the people in the home. That is where we have lost, this is just my opinion, where we have lost looking after people, looking after patients. We're just filling out forms left, right and centre, ticking boxes, and we think we've done a good job. The problem is this lady, Mary, as you said, that's the important in all of it. Not 135 different documents to be ticking boxes. It's just a comment.
And I hope that our Luton residents would be able to, you know, more of our residents would be able to recognise Mary's stories as their experience, but we know it's not universal. So yeah, you're absolutely right. That's what we need to aspire to. It's all about personalisation, keeping the patient and the family at the centre of everything we do.
And yeah, just to add, it's our job on this committee, isn't it, to drill down through all the bureaucracy to see how this is going to affect the patients of Luton. Okay, thank you, Nikki. I think you're on for the next item as well. Primary care access in Luton.
Yep. So I have an update again. So I think all of you are fairly familiar. I do emphasise that primary medical services are offered 365 days a year, 24/7. So our primary medical practices, GP practices, along with the 111, that's the offer. And I say always in any forum I'm in Luton, ideally, if people know their GP practice's telephone number, or they have the facility to use the internet and they are happy to use the online, or I can confirm all 25 practices doors are open. So if people prefer to go in and make an appointment in person, but if they can't get through to the GP practices, they can ring the 111. I always state, though, that the 111 shouldn't be seen ideally as the first point, but if somebody has urgent same day needs, you will have the phone answered and you will have your concerns aired with a clinical advisor, and if necessary they will transfer you to one of the clinical team that sit in the clinical assessment service, which may include a GP. What I've done here is I've given you the appointment numbers, just because people seem to like the appointment numbers, and it's to emphasise that in January we were 32% more than the previous January. In February there were 27% more appointments than the previous February, and again in March 21%. And again, it's just to reiterate, I need some help with myth busting. So our GP practices are seeing patients, and you can see the numbers. That's just the Luton numbers. And we were asked to state how many of those GP practice appointments were face-to-face. So you can see it's 77%, 76% and 77%. I was asked just to clarify what that percentage meant. It is of all total appointments in the practice. The work that we're doing at the moment is and we're doing that with colleagues in Luton and with the other places, is to really work with the residents to help understand that it isn't always the actual GP you need to see. So GP practices increasingly have some amazing staff. Now, I'm going to pause, because it doesn't help when you have panorama programmes that talk about, and I watched the programme and I was horrified. And I'm not sure if any councillors have seen that. My team have done due diligence, because in Luton we have 2 practices run by OPROs. They actually don't have any physicians assistants there, physician associates I think they're called. They don't actually have any there. But even if they did, we are looking at all, with my clinical colleagues, we're looking at all practices that are using any of our other roles to make sure there's really, really good support, daily support, but also good induction, good continuing professional development. And I can honestly say I'm heartened that we do have that. So all 25 practices are working with our primary care training hub. And it's the primary care training hub that are helping to recruit the additional staff. And again, forgive the acronyms, we've called them additional role reimbursals, ours. And in Luton, we have benefited from that additional staffing levels. In the paper, we have included here about the GP community pharmacy consultation service. And just to again demystify it, what we have to try and give the GP practice a bit more capacity, if patients come forward with conditions that could be managed by local pharmacists, who, remember, a fantastically trained local facility, is that there is a direct process where you can refer the patients seamlessly. So just to break that down, of our 25 practices, we've got 5 that are still in the pre-engagement stage, 4 that are almost there, and 5 that are ready to use it. Now, I'm encouraging people, and we're doing this through Health Watch, that members of the public don't have to go through to the GP practice to be referred to the community pharmacist. If you feel that you've got a self-limiting condition, or you think the local pharmacist could help, please, we're encouraging patients to go direct to the pharmacist. But it's about encouraging that there are other options that people can use. So that is that part, which is the day-to-day working in Luton. The only thing I wanted to raise to you, and you may have seen it in the newspapers, because the end of May, 26th of May, there was a publication, an NHS-EI publication. It was it's been nicknamed the Fuller Report, but it's very much about how primary care can work in the future. And it was the report was commissioned by NHS-EI because, as you're aware, media are very, very hot on the public not being able to access GPs and primary care practices. And equally at the same time, the Royal Colleges and the GP workforce are saying, and we've got evidence they've never worked harder. So there's a disconnect. One lot of people feeling that GPs aren't practices aren't seeing patients, and then the workforce saying that actually they've never worked harder. So that report was published, and in effect it's got 3 key areas. And I'm pleased to say in Luton we are at the beginning of that journey, so we're doing the right things. So the 3 areas are about really getting prevention at the heart of everything we do, and that's what working with Mark and Sally and other colleagues in the Luton Place Board is really to get our primary care networks at the centre of our place boards, because it's all about the populations we serve. So that's one element of her report. The other 2 are more probably urgent, which is about how we ensure that our public and our residents feel that they're getting really good timely access to what we call same day urgent care needs. And again, with this committee, I would really welcome how we could work with you, because there will be some transformations, some redesign. So, for example, we are having conversations with some of our GP practices. We started it today about how we can get the practices to work together, where we have one platform that all telephone calls get answered in a really timely way. So at the moment, we know the current status is that some telephony systems are advanced, and they will say that, you know, you're 7th in the queue and they give you that facility. Some you just ring and it's very frustrating. And what's worse is some other practices, you get the engaged tone a lot of the time, because we know there aren't enough lines in and out to meet the demand. So that element of the Fuller report is how do we work with the 25 practices and the people of Luton of how we get same day urgent care. And often that is to people who what we call are infrequent users. The third part of the Fuller review are the people like Mary in that story that I described, where people have perhaps some ongoing long-term conditions. In her case, it was diabetes and dementia, where they absolutely benefit from that continuity of patient care and with with a GP and a team. So those are the 3 elements. Is how do we work with those 3 elements to really improve the current experience of our patients, residents on accessing GP practices. I do stress, because I know there's counsellors on this call that have some practices that are exemplar and they don't have any problem. What I need to be doing is to make sure that all the residents in Luton have a really excellent service. So I will in future meetings go through the Fuller report, but it was just to give you that. I've given you the link if anyone wants to read through, and I've also sent some slides to Chair that we can circulate after the meeting. But probably I'll pause there, take any questions.
Thank you, Nikki. Pat.
Just a couple of questions. I might have missed it, but how are we directing people to the community pharmacist? How would people know to access that?
You know those booklets, and I think Sarah Frisbee may have come on a previous meeting, is about there are various options. So I'll pull that out because I know we've got it as an electronic link, but we did it as leaflets to patients. So that is various options, but in particular, if you didn't know anything about it and you don't come across a leaflet, what happens is if I rang my GP practice and they believe that I am a good candidate for what they call the GP community the community pharmacist GP scheme, they will refer me through for that service. So it should be seamless to the patient. But all I'm saying to you earlier is that if people increasingly get to realise what they can get from the pharmacist, they may go there directly anyway.
I've got another question. I do appreciate, I did hear what you said about the raising numbers of how much bigger it is this year than in previous years. But at Healthwatch, we have had a lot of calls from some GP practices about how difficult it is for them to get an appointment at some practices.
Yeah. And in fairness, we absolutely will be working, and I know we've already started those conversations, but you at Healthwatch, because what I'm very aware is the residents of Luton will have different needs to the residents of Milton Keynes. They'll have the different, needs to Central Bedfordshire and Bedford Borough. So that's why we want to do it at a place level. And then my task is to make sure there's a universal offer at the Blmk system. But this is all about local and addressing local issues. And I think we mentioned earlier when I was saying that the seldom heard is that we absolutely know that there are some members of the population that just don't come forward and probably need health services more than anyone. So it is all about, our mantra has to be about how are we addressing inequalities and how are we absolutely working. And that's working with Sally's team with public health about using population health data to really recognise, where we need to make most impact.
Thank you.
Yes, can you tell me where we are with missed appointments? Because it was running at a very high level, certainly at my practice.
Yes. So you mean what we call do not attend, where the patient makes an appointment, doesn't turn up?
Yeah.
Yep. So those numbers are high. It's reliant on GP practices monitoring it. And my team have also said that this is something that the national team should try and put onto the GP computer systems so we can share that data at system level. But you're quite right, and anything that we can do or you can do to help us to state that, how do you get patients to cancel? So there are telephony now that make it much easier for people to cancel appointments. So again, very, very happy. And that's the level of work that we need to do at each of the 25 practices. So if I've made an appointment and for whatever reason I can't make it, it needs to be absolutely straightforward for the patient to know what to do to cancel it. Because if the only way of cancelling it is to ring up and you can't get the phone answered, well, people aren't going to answer. So, yeah, we'll take that. I know that's on the list, but we will particularly take that as an action for Luton, because I think the DNA rates were higher in Luton than other areas.
Thank you very much, Chair. I sometimes have trouble getting an appointment with a doctor. I can take 2, 3, 4 days. You're supposed to ring at 8:30, and by the time you ring, the phone's busy. 10, 15 minutes, you can't get through. Eventually you get through, all appointments are gone. Ring back at 2 o'clock, you ring back, same thing. And I was so frustrated at one time, and the receptionist told me, if I don't like this surgery, go somewhere else. And I thought that is one of the most terrible things to be saying to a patient. And as I say, in the end, I ring 111 and they got me an appointment. I shouldn't have to do that.
You're absolutely right. You shouldn't have to do that. And let's you and I just have an offline, because that we need to potentially put as a patient story, and we can anonymise it, as they say. I'm sorry you've had that experience, because that's really not acceptable. And in fairness, I'm pleased, but to ring the 111, because I've told you that the practices have to offer directly bookable appointments to the 111 if your case, if you've been clinically assessed as needing same day. So I do stress every time I speak to you, or as a committee, the 111 isn't a way of making an appointment, but if you are clinically assessed as needing the appointment that day, they will make sure you have an appointment. So I would really value, as I say, let's take that as a patient story, and that shouldn't happen at all. And that is the purpose. If you have a look at the slides again, on the fuller review, so we've got a universal offer that nobody has that that experience that you've had.
Okay, thank you. Thank you, Nikki. Thank you. Okay, moving on to item 11, update on the impact of universal credit.
Thank you, Chairman. Good evening, members. Nice to be here again. So this is the latest in our series of updates on the impact of universal credit in Luton. And I haven't got any information to add to the report, but I'll just point out 4 small points as we go through. Obviously, the impact of the cost of living crisis is making the take-up of universal credit and welfare benefits to be quite changeable at the moment. I would just draw your attention to item 4, that in May, the managed migration to universal credit, which was suspended during the COVID pandemic, has now restarted. And Luton, as we know, is right at the end of that process, but by December 24, the expectation is that everybody from legacy working age claims will have migrated to the universal credit. So as normal, at point 13, we provide information in our template format of information about households of concern. Our monitoring is shown at point 16 with the usual RAG analysis, and we have colleagues from our housing department who provided a narrative from point 20 onwards about the impact from the housing team, and that includes the increased detail that we previously been requested by members. So happy to take any questions, or if it's on the housing side, we'll come back in as a written comment.
Thank you, Nigel. Any questions? Thank you very much.
Thanks, Jim.
If we move on to the last item on the agenda, the work programme.
Okay, sorry. Yeah, the note 2 for the recommendation is not just to note it, but to decide if another report is required. Obviously, we haven't actually decided that yet. I would suggest that we'd like one at some point, particularly as you've already alluded to, we've got a cost of living crisis, inflation is going up hugely. I'd imagine that one of the offsprings we could expect from that is the use of universal credit and new claims for universal credit to presumably go up as this cost of living crisis hits more and more people. So I would suggest that we would like one at some point.
Thanks, Steve. Yes. So do we need to have a discussion about this and the timings and frequency of these reports? This is the health social care group, so we need to try and, if we have these reports, to link this to its impact on the health and of the community. So perhaps we could have a discussion offline about that, about how we structure this report in future and the frequency. If that's okay. Okay, thank you. Work programme.
Yes, Chair. So you have the work programme before you for any comments or changes. Yeah, thank you.
Okay, thank you. Does anyone have any comments on the upcoming work programme?
I think some time back we talked about sickle cell treatment and update in Luton. The reports still haven't come, so I'm not sure whether there are any plans to come and talk to us, update us about how sickle cell patients are treated in Luton and what services are available.
Nikki, was that something that you were looking into?
I will find the email, but I definitely know that there was somebody who responded. I'll check with the chair. I'll check the email, but I do have the contact name, so I will facilitate that via yourself, asking them to come and give an update.
Thank you. Thank you. Okay, so that's the end of the meeting. Thank you, everyone, thank you to all the reporting officers, all the contributors, and thanks to everyone else.